Giovanna gave me an interesting task, which was to try to do a summary and really take notes of what went on during this conference today and try to put it in patient speak and try to put it in order for you. And so I hope I've done this. This is my group here in Northern California. We do a yearly run at the Oakland Running Festival. This year we got over 100 people to run with zebra stripes on. And so I'll talk about this little dude right here, who happens to be my son, because what happened is earlier this year, actually 4 weeks ago, he gave a presentation to his 4th grade class on neuroendocrine tumors. And when I was thinking about this last night, I kind of said, well, actually, maybe what I should do is answer the questions that he was asking and that he presented to his classmates as a kind of a framework for how I would look at all the information that was coming. Because at the end of it, when we worked this out and when he worked out his research, he wanted to know a couple things. He wanted to know who discovered it, how do people get it, not necessarily me, but how do people get it, how do we treat and track it, and how can we help? And so this isn't the first time I've turned to him for inspiration. 2 years ago, I wrote an article for the ASCO Post on neuroendocrine tumors, and I was having problems figuring out how to write this particular article. It just so happens to be Dr. Seuss's birthday. And this is a picture of me reading in my pajamas to his class, You Don't Know How Lucky You Are, which was start of one of my articles for the ASCO Post. And the next year, he actually did a thing about cancer to his class as well. So that, I'll kind of bring that through here as well. So the first thing we heard a lot of stuff today. And we heard a lot of stuff that could be a little nerve-wracking. But the first thing I want to tell all of you is don't panic, right? A lot of you are newly diagnosed. This is what we heard earlier today, a marathon, not a sprint. Some of us need to sprint, but most of us, this can be a marathon. So let's go and see if I can answer his 4 questions with what we learned today. This was actually presented. This is actually his thesis on Carcinoid. But this is Obendorf in 1907. And interestingly enough, 10-year-olds really want to know who discovers everything. So this was an important slide to him. But who discovered it was our first speaker. Not our first speaker, but the type of speaker that we had, a pathologist. That's who really coined and really understood what was going on here with carcinoid, although he called it cancer-like, which of course has become a problem for us. But what did we learn from pathology? Get your report. Know what it is that you have so that you can share it. Know your Ki-67, because that determines a lot of the options that you have for treatment. It's really important to understand that. Ron was reminding me that our friend George Fisher, Dr. Fisher at Stanford, likes to just use a simple thing. Well-differentiated, well-behaved, poorly differentiated, poorly behaved. These things are easy to remember so that you can understand it. You know, we're here at City of Hope. We had a great pathologist talk to us, and most of the people who see a NET specialist work with pathology that really understands their disease and can do a pathology report. One of the interesting things that I found several years ago, I think it's 4 years ago now, a Stanford pathologist was doing a study on all the pathology reports that came to them from community hospitals. And the one thing that was a little disconcerting, especially if you've gone to a community hospital, is that 1/3 of the pathology reports were misclassified. They were, and that would lead to a change in the grade or the differentiation of the disease and their treatment options. So if you've had your pathology report done at a community hospital, when you go see your NET specialist, it may be time to have another look at that, and they will usually do that. So one of the things we didn't really discuss, but I like to bring it up because we're in a room with people. I mean, how many people here took over 5 years before they got their diagnosis? Show of hands. We have a disease that's really hard to diagnose, and that's not uncommon for us. So we don't always know how to talk to our doctors about our symptoms. We don't always can describe things correctly, but the really interesting thing I find about NETS patients in general is that once we get diagnosed, we're pretty confident that we know something about our disease because we've been working so long to figure out how to get diagnosed. But this is something that was done by the Global NET Survey, and you've got 34% of us needed 7 or more visits to get diagnosed. Earlier this year, this isn't exactly on getting diagnosed, but this was on speaking to your doctor or your oncologist about your disease. I hosted a panel at ASCO GI on how to actually communicate. Giovanna was part of the panel as well, on how to communicate with your oncologist. And this was just made into an article for Cure magazine, and you can get it just by doing bit.ly. Speak Up Cancer. So really, we need to inform our doctors because they really can't help us unless they know what it is that's going on. And it's incredibly important. So what was, my son's second question was, how did I get this? And the year before, he did an entire presentation on cancer, which turns out most cancers are lifestyle related, but it just turns out not this one. So this one's a little harder because we had a talk about hereditary and MEN1, but that's not most of us in here. Most of us, it's a sporadic case of cancer. It just happens, and we don't know why. Unless you have multiple features or some of the things that were discussed about hereditary, you probably just have a sporadic cancer. That being said, even though this is not a lifestyle, as Leon was talking to us, really we have to really watch our diet, nutrition, all the things that lead into lifestyle cancers are something we need to really think about in our ongoing cancer journey, because really it's all about nutrition for us. So yes, a balanced diet, manage for your condition, limited added sugars, saturated fats, exercise and stress reduction, these are all going to help us get through our cancer diagnosis. And that leads to the other thing is, well, we don't really know exactly why this cancer arises or how it arises. So we really are trying to better understand the biology of this cancer and really how it starts, because we can have lots of drugs that come out, but unless we know why they work, how they were meant to work, we're not going to really get to the next level and get towards a cure. Which brought us, whoops, wrong way, which brought us to Ron and Dr. Halperin's presentation, where we were really trying to figure out where this comes from. This is a lot of research, and you can see the type of things that the NetRF group, our foundation, had funded in the last year, trying to figure out where this starts. How does the original neuroendocrine cell become cancer? The fundamental question, so we can figure out how to turn it off, not just potentially treat it and then figure out how to play whack-a-mole, but really to shut it down. Okay, so we have different targets, different areas that we're looking at to really understand the biology, understand how we might look at the immune landscape so that we can actually figure out targets and build on immunotherapy, which is a little bit more difficult in our case. Which brings me to other things that Dr. Halperin was talking about, and other people alluded to this during the day. We're not so rare anymore. We think we're a pretty rare cancer, and I know there are pluses and minuses to this, but the incidence now is much higher, 7 per 100,000. Approximately 21,000 new cases in the United States a year, prevalence of 172,000, and that's because we're having, more diagnosis and an increase in overall survival since the 2012 studies were done. This has implications for us because a lot of the drugs that we get come to us by orphan drug designation, which means they might be require less members to be, or less patients enrolled in a clinical trial. They may be fast-tracked. So there's a plus-minus here is that there's more of us, and there's a strength in community and a strength in awareness, but it may be more challenging to get drugs done in the ways that we've been getting them done before. And as was indicated earlier, this is the second largest GI cancer. So this is just going to increase survival. We were talking about the different areas, and it turns out we used to be lumpers, now we're splitters. So it looks that things are different depending on where your disease is. But whatever it is, over the last set of recording time, we're increasing our overall survival. And that's a really good thing, in that we're going to keep on doing that. And with the research that we're doing, the new drugs that are coming out, our overall survival will keep on improving. But one of the things that we talked a lot about different parts of the treatment paradigm. But we really didn't get back to the fact that, you know, when we're looking at this, there are sets of guidelines. We talked a little bit about the ENETS guidelines, which are the European Neuroendocrine Tumor Society's guidelines. There are the North American Neuroendocrine Tumor Society guidelines. And then there's the NCCN. I realize if I point with my finger, no one will see it. The NCCN guidelines, which were just recently updated. Now, this is not exactly something you want to take home and read on a weekend. It's 197 pages long, but it does really give a great idea of at least what it is you're looking for your particular disease, and what you should consider and where you should consider. So it's something you should know, so you understand where your physician is coming from and what those options are that he's talking about. Now, this is not perfect. You can see we're pretty clear. Surgery first, somatostatin analog second, depending on the disease type. Again, that's not always the case, but that's pretty close. But then we get into, you know, the favorite part, the ORs. There's a lot of ORs. When you get past the first two, we're still not sure exactly where to go. And this is something that is challenging, as we saw in the last case presentation. Where do you go? Because there's not a clear next line therapy. And this is something we're going to have to keep learning about. So I'm just curious, a show of hands of those of you who are left here, but how many of you have changed treatment in the last year? So changed, added a different treatment or changed the treatment you were on. So I'm going to go, not that many, interesting. How many of you are in that inflection point where you're looking at changing treatment? So 1, 2, yeah, about the same amount, interesting. So these are the basic things we talked about, right? We talked about surgery, we talked about risk versus benefit, a lot like real estate, location, size, although the symptomatic part probably isn't part of real estate. But we should do surgery to avoid complications. Liver-directed treatments I'll get to later, as well as somatostatin analogs and systemic treatments. But this is something that, these are our options. This is what we're looking through. And Dr. Singh in the morning presented liver-directed therapies, and really a good point to remember was that the liver regenerated in 3 months. And his big point, and I think we heard it in the last case that we saw, was let the liver recover. Let it get back to where it is without keep hitting it with treatment, and you may, it may survive to see another day. And these were some of the things that we looked at when talking about what you could do in the liver, which whether this is mTOR inhibitors, which would be things like everolimus, and these are the things we've been talking around throughout the whole day. But how did we get here? So the next thing I wanted to really talk to you about was the other parts, which were really the set of treatments that brought that overall survival and that the increase in overall survival that we had. So as Dr. Halpin pointed out, streptozin was the first drug in 75. In 86 is when we got octreotide. Promid actually didn't get the FDA approval. It was approved in 86 for the treatment of symptomatic carcinoid and vipoma, and acromegalia. We also used interferon back then. So this is what we did. And then there was a big gap. So it's 20 years, 19 years before we started using temozolomide for neuroendocrine treatments. And then we got an approved agent in 2011 for sunitinib, everolimus, lanreotide, and then everolimus, and just recently telotrestat for the control of diarrhea, as we learned, for people with carcinoid syndrome, and we're waiting on Lutathera for that. Now, you can see large gaps in the treatment, in the times, but now you can see in 2011 when the latest data we're now looking at is showing that overall survival is improving. Well, we had a whole bunch of new drugs come in here, and maybe that's part of the reason. But getting these new drugs is not an inexpensive endeavor. Anyone who hasn't been in one of my support groups before, throw out a guess of what it took, how many years and how much money it took to get telotrestat out into market. And no looking on the internet. Above or below 500 million? Above. 800 million approximately. How many years? From the inception to delivery? 20. So this is the type of time that it takes to deliver drugs to our community. So if it's going to take that, we better know what they're going to do, and we better know that we're on the right track. Lutathera is hopefully soon come, very soon. A little sadder story, we saw, we heard a lot about gallium-68, so let's talk about the evolution of approved NET imaging agents, which is a kind of a sorry graph here. We do have conventional imaging, but in '94, the Octria scan was approved, or the imaging agent for doing that, and then it takes to 2016 until we have the next imaging agent. So it's been a while. There are some caveats. We've heard a lot of different things, and I'll talk about the imaging in a second, but this was just a paper done by Professor Graham in Iowa about looking at 400 plus studies. We learned about carcinoid syndrome, and that we can control syndrome with telotrestat, and it's now part of the NCCN's guidelines. But we also talked a lot about clinical trials, and we only mentioned a few of them. And I wanted to point out clinicaltrials.gov is now, has changed over. There's a new site. It's easier to navigate, easier to find, more information. There's checkboxes so you can look at it. But I just, for curiosity and sake, today ran a thing just for neuroendocrine tumors who are recruiting phase 2, phase 3 in the United States, and there were 161 studies. So even with that, you really need to talk to your professionals about what it is that meets your criteria, because 161 studies is a lot to go through. It's really hard to narrow that and focus that down. So you really need to talk to your specialist, understand what's near you, but also understand what's available. But I encourage you all to check out the new site. It's much better. One of the things, we also talked about clinical trials a bit, and one of the things that I think we missed a little bit, we understood overall survival, we understood progression-free survival, but what we didn't really talk about is it's really hard to compare trials. Okay, you need to understand the entrance and exit criteria. Our last case showed a bunch of different trials, but they don't necessarily had the same entrance criteria. So even though one of them had a PFS of 6 months versus 16 months, one of them might have been requiring people who were stable for 12 months before they could enter the trial. They're going to perform a lot differently than people who are progressive entering the trial. So when you're looking at a clinical trial, and certainly at the results of the clinical trial, it's hard to cross-compare trials because they have different entrance criteria and different exit criteria. So please make sure you understand that, because they're not cross-comparable. Okay, so his next question was kind of like, well, we've got things, how do we track disease? Well, actually I thought that was done really well. The first thing, the most important thing is, how are you feeling, right? That's really it, because we treat patients, we don't treat numbers on a test. You are a patient, you have symptoms, you can talk about it, you can talk about whether you can get out on that bike ride, whether you can get outside at all, and that's really the most important things. Biomarkers, is there a right one? We heard there was several ones that we use in general, but there's no necessarily perfect biomarker at this point. We really, when we see rising elevated markers, we need to look at increasing surveillance. We need to stay consistent with the labs we use once we do that, because someone's elevated marker, once they're elevated, does not cross-correlate very well as well. And then we saw some research on creating better biomarkers and more interesting biomarkers. And imaging, the thing we learned here was consistency that you can measure, that not every single time the lesions are going to be measured exactly the same, but you need consistency, and you need to make sure that the people who are reading it understand, really focusing on the trends and what's going on scan by scan, and even looking back a few scans. Stable is good. So we get disease really stable. Just a little progression or stability does not mean you need to go into treatment. Stability means that you're where you're going and can keep going for a long time. So we learned a lot about NetSpot today. Several different places brought it. That is not the NetSpot logo. It's just one that I happen to like, got gallium-68, because a couple of things that I want to make sure that you guys really understand. We use the word gallium, we use the word gallium scan and gallium-68 interchangeable. We're not the only guys getting gallium scans now. Even before gallium-68 came out, there were gallium-67 scans. I've had 2 members of our support group who badgered their physicians to go get gallium scans and got gallium-67 scans. And that one does have a lot more energy, and it doesn't tell you anything about neuroendocrine tumors. So you're getting a gallium-68 dotatate or a NetSpot scan, because we will have gallium-68 scans for, and we do have them already for prostate cancer. And it's really becoming, going to become one of the standard scans for prostate. So be specific about what it is that you know how to do, that you're interested in. We had some questions about how to read them. And not that I suggest you all become trained readers, but it's publicly available. You can actually, it takes about an hour. You can go through all the cases. If you just use that link, bit.ly/gallium68read, the Society of Nuclear Medicine has free reader training, and you can learn how to read your own gallium scan if you really want to. This is Ken Herman's slide on PRT. What was interesting is that Ken was trying to show us about, Tate, Talk, and Knock. We can add reporting units, gallium-68 or 177 Lutathera. Looking forward, there are things, there are other peptides that we can link with, which we heard about JR11, the antagonist. There's also other radionuclides, although some data was presented about Y90 in the use of PRT. We just saw a trial yesterday opened up on clinicaltrials.gov doing intra-arterial PRT at UCSF using Y90. Not only it's a different delivery method, it's going up through the liver, but it also uses a Y90 isotope. We also heard a little bit, not much, about alpha particles, which may have the potential of even producing better results or killing more disease and potentially lower side effects. So this is going to be an area which will really increase in the next few years, which is really kind of exciting. But we did actually see many things, that PRT is 20 years old, that we have expanded access with Lutathera. We heard about the antagonist. There's multiple isotopes. This was the curve that showed the great survival advantage compared to the control group, which was double-dose octreotide. But we're going to learn things about combinations with other treatments, whether they're with CAP-10, which is a possibility, or other items as well. And we have new trials that are coming up. The COMPETE phase 3 will compare this against everolimus. The control Net is the comparing against or using the Cape Tem to add to see if it radio enhances it, and I just talked about the new pilot studies. So brings me to my last slide, which was good because I just got the 1-minute hook. How can you help? I mean, so you've been sitting here and we've been listening. So one part of being a community, and as Giovanna said, great things can happen when the community gets together. We can get other people treated. We can learn new things. We can set up new relationships. But we can do something else much better because we really already have. And we can continue with that. Our voices can shape policy. A room like this was, there was a conference in 2015 with 70 individuals that came into a large nuclear medicine conference, patients who gave their voices to the need for gallium-68, DOTA, whatever, for neuroendocrine, and the FDA sat there and listened to that, and because of that, they really streamlined and accelerated how gallium-68 PET-CTs would get into the neuroendocrine tumors. There's healthcare policy. Many of you all of us have something that will be affected by the upcoming discussions with healthcare policy, and if you're not sure how it affects someone with a rare disease, please go to raredisease.org to understand how it might affect someone with a rare disease, and make sure your senators and representatives understand how you feel about your own health care and what you need for your well-being. We can shape care. All the hospitals that I know of have patient advocacy boards, have boards where you can help form policy on how patients get treated. The research cooperatives that do all the clinical trials do take patient input and have patients on their boards looking at clinical trials. Myself and Carrie Brentro have been serving as the, for the NCI, the patient on the patient task force to give the patient voice to clinical trials that the NCI does. The FDA has a patient program that has 65 patients in the country that are part of that patient program, giving voice to patient needs in drug development. But we can also shape research. Since I know, well, we've had a few people I already know who are on the PRRT trial. How many people have been on clinical trials in this room? So we have people who have participated in clinical trials, and that's how we get our answers, and that's how we get drugs out into the market. We can actually also shape whether we're donating locally, nationally, or internationally to help really raise both awareness and funds to get into research. And we can do this through our support groups like you do here at LACNETS, through your research centers where you get treated, or through national foundations that provide the grant money that put young investigators out that answer these big questions that are happening like NetRF. And with that, I want to thank you. I hope that was a good summary of the day, and really appreciate your time.